So thank you, ISMPO. Thank you, chairpersons. And till Dr. Shona fixes a glitch, I will finish my talk. So my job is to what's new in the neoadjuvant and the adjuvant scenario in the non-small cell lung cancer. And if you look at it, why at all would need to talk about this is because still in lung cancer we're in stage 1B, and that's where I start off with the operable lung cancers. You would find that around 50% or 40% of them would be having a relapse, and even as you go down the stage in stage 3, around 70 to 80% will relapse at some point of time in the next 5 years. And that's why we need more effective systemic therapies. We have had advances, but I think it is not enough, and we need to cure our patients more, at least in the operable lung cancer scenario. So why neoadjuvant approach? I'll first touch on the neoadjuvant approach and then go to the adjuvant. If you look at it, people have a more improved physical fitness and compliance. And if you look at the whole scenario, and that's why this lecture is all about breast, now in lung, then we're going to GE, the colon, except the colon cancer, even the rectum. We are now shifting from adjuvant to a part of the therapy, at least to the neoadjuvant scenario. And that's how the world is moving. And if you look at it again, there is enough data across, and especially lung cancers, that approximately 20% of patients, because of their post-op complications and because of the toxicities which they go through after the surgery, they are not able to take any adjuvant treatment, and that could be alleviated if you are going to give a neoadjuvant approach to all these eligible patients. And the most important after that, and the example can come from the triple negative breast cancer, that we have seen that if you give a neoadjuvant, you see the adaptive response to tumor to systemic treatment, and then you make adjustment in your adjuvant treatment. And that is also how this neoadjuvant approach has helped, that if the response is complete, you probably do not need anything. If the response is incomplete, you need to change your treatment. We have seen in triple negative breast cancer, we've seen in HER2 positive breast cancer, and lung cancer scenario also would not be much different. And why is there such a big focus on immune checkpoint inhibitors? Because the main focus in the lung cancer scenario in the neoadjuvant adjuvant is on the immune checkpoints. So the point is, you get the opportunity to study the dynamics and the mechanism of the anti-tumor response. The proposal is that if you give a neoadjuvant immunotherapy, you facilitate the early development of the memory T cells, and they induce a strong adaptive anti-tumor response. And that is most likely the most important potential advantage over adjuvant immune checkpoints. And if you look at it, it has been demonstrated in the triple negative breast cancer. It has been demonstrated in the melanoma setup. So basically, this take care of the micrometastasis, and this is how, because you are developing the memory T cells against these cancer cells. And that is probably why immune checkpoints are such a big interest in the neoadjuvant scenario. And how do we assess the thing? The major pathological response is the primary endpoint, and this is something very unique. You do not look only at the path-CR. In lung cancers, you look at the major pathological response, and that is less than equal to 10% viable tumors should be there. And that is something that is easier said than done. It would be definitely need a good specific dedicated pathology team, because they need to look at the specimen in total. There could be a good amount of necrosis, especially in the squamous cell subtype, and you need a surgeon to orient the specimen. So easily said than done, but that is how the world is progressing. So now a word on neoadjuvant TKIs. Do we have data? The data is very sparse. The trials numbers are small. They usually have given the neoadjuvant TKI from as low as 1.5 months to as long as maybe 2 months, 2.5 months. The most data is from 42 to 56 days. And the largest data from the neoadjuvant TKI has come from the emerging CTONG 1103 study. This was nothing but a 386 patient screen. 72 patients were then taken up, and they were randomly assigned to receive erlotinib versus a gemcitabine chemotherapy. We can argue about it in adenocarcinoma. Is gem the right regimen? But that's what the data is. And they specifically looked at the N2 positive patients who had N2 nodes. This was basically a bulky, large stage 3 patients. And to cut the thing short, in the very short trial of around 70 odd patients, you had more responses in favor of erlotinib neoadjuvant, and which was given for around 56 weeks, 1.5 months, 42 days. And you did have a numerical advantage of the allotinib, but which was statistically insignificant. The OS was similar, but there was a progression-free survival in advantage to the TKI over the chemotherapy. So if you look at the major pathological response, it was seen in around 10% in the allotinib group in this subtype of patients who had EGFR mutations, and there was no responses in the chemotherapy. So this does give a setting that a large trial should be run with this group. Probably osimertinib would be a good drug to look at. But the main focus has been the neoadjuvant immune checkpoint. There have been multiple studies. There are studies on single agent immune checkpoints. You have data across nivolumab, atezo, durvalumab, and you would see that it has been from 1-2 cycles to 4 cycles. There has been across, and they have taken resectable lung cancer stage from 1B to stage 3, and you would see that the pathological CRs are around 8 to 10 to 15. Maybe some trials have reported around 40%, but you do not see much of a path CR. You see major pathological response to be higher. And if you look at it, the objective response is not great, but around 1.5 years time, you would see 80% of patients or 75% of patients still doing very, very well. So with that concept, you have a small study of the NeoStar, which is a IO combination. This proved, and this compared a single immune checkpoint versus a dual immune checkpoint. And this proved that if you have a dual immune checkpoint in the small study of 44 patients, you had major pathological response in favor of the dual immune checkpoint response. The toxicity was as we know for other things, but this data does tell us that the dual immune checkpoints have a future, and at least in the PD-L1 expressing subset, they probably are a better agents to choose. This is one data which is probably going to change the way we practice. The CheckMate 816. A neoadjuvant nivolumab and a platinum chemotherapy. These were patients with newly diagnosed resectable beyond 4 centimeters. At the 1B to 3A did not have any EGFR or ALK or any, did not have these two driver mutations, and they were of PS 0 to 1. They were randomized to nivolumab 360 once in 3 weeks plus chemo versus chemo. At least 3 cycles were given, and then after 6 weeks were operated, and the adjuvant treatment was optional plus minus radiotherapy. That was what it was, and the primary endpoint was the path CR, and that is what was looked at. Nothing much to tell you, just to tell you that the PD-L1 expression was there in around 50% of patients, and around 50% were squamous and 50% were non-squamous. The smoking status was positive in around 90% of patients. That's something very, very significant. What was the take-home message for it? The PAT CR was much, much superior if you added a nivolumab to the chemotherapy arm. That was seen more so in stage 2, stage 3, and stage 4 patients. And if you look at it, the nivolumab and chemotherapy, it was 24% across the patient group versus only 2% in the chemotherapy alone. And all of us know, achieving maybe the complete pathological response, these patients do better. And this combination of the immune checkpoint and chemotherapy also led to more complete resections and lesser surgeries, means more of lobectomy rather than pneumonectomy. And also, if you look at it, the thoracotomy and the minimal invasive surgeries, the thoracotomies were lesser and the minimal invasive surgeries were more, and the conversion to open surgeries were lesser if you added immune checkpoints. And the toxicity, nothing much to harp about. The combination was good enough, well tolerated, and is doable. And there was nothing to talk about the toxicity which could hinder this approach. But many questions still unanswered. How many cycles would you give in a neoadjuvant approach? Is it 2, is it 4, or is it more? Could we combine a CTLA-4 inhibitor like we did in the NeoStar? And if yes, can the chemotherapy cycle be reduced? Because there we looked at only 1 cycle of IO combination. And what would be the optimal adjuvant chemotherapy? Do we need something like, let's say we achieve a path CR? Just can we take away chemotherapy and give 1 year of immune checkpoint? Would that be enough? Or is anything at all required? That questions are unanswered. The PDL status and the response, and do we need a PDL status to be done? And the driver mutation positive, I don't think this is a very good approach for these patients. Coming to adjuvant, we all know that we give the chemotherapy 4 cycles, 3 cycles, or 6 cycles, depending upon the type and the load of disease, to get that 4-5% or 5% advantage. This is well known to all of us. But look at this data, and this is probably the most path-changing trial which has happened. The IM Power 010, adjuvant atezo in the group of patient 1B to 3A, more than 4 centimeters, and these patients had to, could be irrespective of PD-L1, and they took adjuvant chemotherapy 1 to 4 cycles, and then they were randomized to Atizo for 16 cycles versus best supportive care. And they looked at stage 2 to 3A group with more than 1%, that is positive PD-L1. This group was first analyzed. This was actually a hierarchical analysis. If this was turned positive, then they looked at all comers of the patient, and that is how the trial went through. And to look at the subtypes, 3A constituted approximately 45 to 50% of patients. Never smokers were around 20%. The non-smokers was around 60 to 70% of patients, and the PDL1 positive was there in around 45 to 50% of patients. The DFS, which was the primary endpoint, if you look at beyond 1% for stage 2 and 3A, which was the first analysis that to be done, was positive. And that was for the hazards of 0.66. Point to be noted that if someone had an EGFR mutation or ALK rearrangement, that was seen in around 15% of the patient subgroup in this 1200 patient data, those patients did not benefit much with the addition of immune checkpoint. So that could be a subgroup which probably we can get away and probably do the ADURA type of thing. And if you look at, because that was positive, they looked at everyone, irrespective of the PDL1 status, and the hazards dropped from 0.66 to 0.79. But in an Indian-like scenario where money is the issue, whom should be the patients? Look at this the score of more than 50% PDL score. And this patient, the hazards is 0.44. Excellent hazards, probably not as good as ADURA 0.17, but something which is impressive. 65% benefit of adding Atizo if the PDL1 is more than 50%. And this could be a group which I will target in my practice for the eligible right patient, stage 2, stage 3A, more than 50% after chemotherapy. If the money is there, could be there who could take 16 cycles of Atizo. Beyond 1%, if you look at that analysis, which was post hoc, 1 to 49%, actually the hazards dropped to 0.83, if I'm not wrong. And the benefit was not statistically significant. So it makes a point that if it is very high, more than 50%, you could add Atizo to this patient on adjuvant. ADURA, yes, for the EGFR positive in the stage 2 and 3A, you could add ADURA and thus give a PFS survival which has never been seen before. So, is ADURA practice changing? I think probably yes, but all the trials which have shown the CheckMate, the IM Power and the ADURA, all of us would love to see the OS data. And that data, if it is positive, I think the questions will stop changing. Can we do with the longer duration of Gefitinib? I don't know, because there's data from the adjuvant Gefitinib data that patients who took more than 18 months did better than less than 18 months. Mind you, ADURA was 3 years and the Jef data was 2 years. So a lot of unanswered questions, but I think at this point in the eligible patient, osimertinib adjuvant is the way to go ahead. And the expert consensus, which was published last year by the Chinese group, consensus: preoperative use of neoadjuvant immunotherapy with or without platinum-based chemotherapy for resectable stage 1B, 3A may be considered. This was before the IM Power real the data came in, and the CheckMate data. The consensus 2, they looked at for the EGFR sensitive mutations. Can we do it? Do we have a biomarker? These questions are largely unanswered. But in the adjuvant scenario, I think in the larger PDL1 status, we should be looking at how many cycles for neoadjuvant. As I told you, 2 or 4. Or if you add the CTLA4 inhibitor, would you do with 1 cycle or 2 cycles? That is something we'll learn further. When to operate? After 4 to 6 weeks is the time when we should be looking at surgery. And for neoadjuvant immunosuppression in non-progressive patient, the consensus more so, although there is no much data to it in a level 1 evidence, but people feel that 1 year of adjuvant immunotherapy could be the way to go forward, at least in the non-progressors. What does NCCN have to say? I checked the last NCCN. For the adjuvant, they've introduced Atizo into the standard of care. For the new adjuvant, I think that is still open. So to conclude, new adjuvant therapies, especially chemotherapy with immune checkpoint, are going to become standard of care. That's something that is important. In the PDL1 positive subgroup, stage 2 and stage 3, adjuvant Atizo with chemotherapy should be offered in mutation negative. And if I look at the experts, Tony Mock also spoke about this, at least in the Asian subgroup where finances are issue, more than 50% PDL1 positive subgroup benefit the most. The hazard is 0.44, and I think that's where it should be. And if you look at it, lastly, the EGFR inhibitor osimertinib, the data is strong for adjuvant scenario. And here I'll stop. And if there are any questions, I can take it or I can be on chat. Thank you. Thank you for the opportunity.